And then this last case, this is a pretty easy one. So again, I think we've emphasized a lot, just make sure to look at your axial images. So again, I open it up and I always look at my axial images. And so again, we're scrolling down, and what's remarkable here is we have an enormous right coronary artery that we're going to have to explain. And so when we follow it, again, we've seen this before, but it's again going to the coronary sinus. And so this is just, I thought, a really beautiful example of a really dilated right coronary artery with a fistula to the coronary sinus. And this patient, I think, had hypertension. And so the primary care doctor ordered an echocardiogram for hypertension. And on the echo, it was diagnosed to have a dilated right coronary. And that's what led to this imaging. But the patient's completely asymptomatic. And it was just based off of a dilated right coronary on an echocardiogram that this was diagnosed from. Yeah, so you really can't differentiate the two. But if you have a replaced pulmonary valve, I have never seen, I can't think of any times I've ever seen it be thrombus, like truly thrombus, and not superimposed endocarditis with that size of a vegetation on the valve. Where it gets hard to differentiate is when you have like this nice thin layer, so more like hypoattenuated leaflet thickening. That is what can be really challenging to say, is this thrombus or is this thrombus or infection? And that's where your PET scan will help. But if you have a mobile vegetation, it almost always is endocarditis. And then typically you're getting the scan because they're coming in with pneumonia or they're showing up with chest pain, and you get the blood cultures and they'll be positive. Sometimes they'll be really slow or growing organisms, in which case those tend to have sometimes the biggest vegetations, and you can have abscess already forming. And those patients can be the ones that are really slow growing from an ID standpoint. But we almost always have been able to figure out what it is, the organism. And these patients, our standard at our institution is we do not anticoagulate because you get more bleeding complications from the infection. And so they may have pulmonary emboli, but their infection that's causing the pulmonary emboli, not thrombus. And so we tend to not anticoagulate because we've just had some pretty massive bleeding complications by anticoagulating the infection. And instead we're doing antibiotics and then trying to figure out our timing for surgery.